Good Friday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement, here for Dr. Steve Stites, our Chief Medical Officer today. He has headed to a stream somewhere to do some fly fishing, hopefully before the rain starts and the flash flooding. I think he's probably somewhere in southern Missouri where he likes to disappear when a weekend appears. The team here has challenged me to get a Star Trek reference in, and that is so much not me, but I'll try and fail miserably. Hopefully we have no need to beam him up out of a river. So there you go. Mark it down, gentlemen. Thank you. When he does dodge the rain, he'll be back here next week. In the meantime, we're coming to you from the Dolph Simons Jr. Family Broadcast Studio. Here with us today, Lance Williamson, Infection Prevention and Control Supervisor, as well as Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control. Dana's here with our numbers this morning. Yeah. We still trending down?
Yeah, you always peg me more for like a Lord of the Rings kind of guy. So.
More than Star Trek.
Our numbers are still good. We're under 10. We were at 5 yesterday, active infections, 8 active infections today, 3 in the ICU, but 2 on the ventilator. So still a large proportion, 66% on the ventilator. 19 in that recovery period, so still the number is the total number is still much lower than we have seen. And Hays has 3 patients, 1 in the active and 2 in that recovery phase. So overall, numbers have continued to be low these past 10 days, 2 weeks, which is a real good thing.
Yeah. It's easy to say, wow, yesterday was 5 and today's 8, and that's a big difference. And of course, percentage-wise it is. But those sorts of variations have happened. 3 patients or even 20 or 30% changes per day have happened throughout this. There just is this natural variation and progression of disease. So definitely not something that scares me yet.
And we've even seen from you when you've presented some of your numbers, even though our total numbers have been the same, you have shown the amount of admissions and discharges that we get too. So it's not just about those numbers, but have we brought in more active infections as well? So.
Yeah. Well, before we jump into our community questions, are there any reporter questions on the line this morning?
Yes, there are. Hello, can you hear me?
Yes.
Hi, good morning, everyone. Bryant Madrick from 41 Action News. I had a question from one of our producers who wanted to ask about this. The question goes, as the CDC is recommending that people who are vaccinated can visit indoors without masks and social distancing. We also have only heard that immunity after being vaccinated is for 3 months. Scientists don't know if it lasts longer. So what does that mean for healthcare workers and others who were the first to be vaccinated? They will be coming up on their 3 months. So is it safe for them to be indoors, unmasked, and not distanced?
Yeah, so that immunity by vaccine is defined by 2 weeks after your last dose. Everything I've seen, they haven't really been very clear on the other time frame that we've heard of in the past. So right now, that's where it stands. It's 2 weeks after your last dose. I'm sure as we get more research and more data, we'll understand better. We know that immunity by vaccine is better than natural infection, at least. So that's good. But right now, we're really holding on to that definition of 2 weeks after your last dose.
Yeah, immunity, especially after mild or asymptomatic disease. The vaccines look to give very good immunity, but it does occur after that 2-week period, after that second dose, or 2 weeks after that single dose of Johnson & Johnson. But I don't think we know, and the CDC has not specified it's just for 3 months or 6 months or 9 months. We are hoping and assuming that you are going to continue to have good immunity to protect you against hospitalization, severe illness, and death for more than 3 months, 6 months, 9 months, a year. But just as you stated, we don't know that for sure. The studies are still ongoing. But you look to have durable immunity, meaning lasting a while, after that second dose. So again, the CDC new guidance for vaccinated people does not really specify a time date, but we were looking at KDHE, and I think they have some time frame in there.
6 months now as a end date. So the clock starts 2 weeks after your completion of your series. So second dose for Pfizer or Moderna, 2 weeks after your single dose for Johnson & Johnson. The question of what is the sort of end clock, I think, is more unknown. But as it pertains to the specifics of, well, what about healthcare workers who are approaching a 3-month, I think the sort of end dates or the stop clock that we've heard, as Dana mentioned, is more related to the fact that that's just the data that we have. And as we get farther and farther out, there's continued study on what immunity looks like. And remember, that's not just antibody levels. I get that question almost every day. And so antibody levels are one measure of immunity, but you still have memory function, and you still have T cell functions that are important in that. And circulating antibodies are not necessarily the single marker. In fact, aren't the single marker of your level of immunity. And so those studies are still happening. I think right now there are people serially checking for those vaccinated what your antibody levels look like, and also the more important question, the clinical question of the marker of immunity, not the laboratory value, but the clinical question: what percentage of those that are 6 months after a second dose of vaccine who are exposed are getting the disease? And so that will be, they think, the real study, the hallmark that tells us what's safe. But as far as do those vaccinated early in the vaccination process here, 3 months ago now for some of us, right, in mid-December, do we need to be worried about not having immunity? I think the answer is most likely no.
More than likely no, yeah. Yeah, I would agree. And again, that's why getting that second dose is so important, because you do get that boost of that adaptive immune system that has saw the spike protein in that vaccine for that first shot. And so that's why the second dose is so important.
Any other reporter questions on the line? All right. Well, before we jump too much into our questions from the community today, I did want to take a minute and go off script and make Jill as uncomfortable as possible.
It's working. I can't wait to hear what you're going to say.
So many of us, I think, either watched or saw summaries of the president's address last night, highlighting that continued push to make sure that any adult who wants to have a vaccine should be able to, by the phasing guidelines, if you will, by May. You know, interestingly, before his speech last night, we were contacted by our partners at Johnson County Health and Environment, and they asked us if we would be able to help manage vaccination for Johnson County residents in Phase 2 in a little bit different way starting next week. And when I say in a little bit different way, I mean an expansion outside of the 65 and over population that had been the focus of all of the healthcare delivery systems in Johnson County, partnering with Johnson County Health and Environment to deliver vaccines to the population. So there's a couple of things buried in there. First, that means, or the bottom line there is, Johnson County is getting more doses next week, raw number of doses. And that will result in more doses going to anyone who can give vaccines next week. And we definitely have the capacity to do many, many more than the 1,100 or so new first doses that we're doing per week. That's due to a number of things, actually. It's due to some influx of Johnson & Johnson. It's due to an increase in inventory of Moderna and Pfizer. And it's also due to the fact that some counties in the state of Kansas have indicated to the state that they are now done with Phase 2. And so their allocation for next week are being redirected to counties that aren't finished with Phase 2. And all that means we'll have more doses, definitely more doses than the 1,100 or so that we've been receiving from Johnson County each week. And also, as Johnson County is moving out of the 65 and over crowd as the primary population inside Phase 2, it means that we will be partnering with the county to tackle more populations. In fact, pretty much everyone else in Johnson County's tiers for Phase 2. And so that means grocery store workers, food processing workers, meat processing plants, restaurant and bar employees, warehouses, manufacturing plants, bus and transportation workers, including Uber drivers and taxi drivers, and a number of other logistics and warehouse sort of things, so the Amazon warehouse sort of population or other logistics. And that's not an exhaustive list. I'm reading off of one of our early drafts. I know Johnson County is going to be more clear about sort of publishing what that means and on that complete list publicly if they haven't last night, sometime today. And the good news there is that we know that there are a lot of people, both that are established for care in our organization that live in Johnson County or work in Johnson County, or that are not, that fall into those populations. We will be able next week to partner with Johnson County to begin vaccinating all of those groups. So what that means logistically is for those of you that are established as patients here at our health system, your MyChart will show a series of questions that will help direct you to your ability to schedule. Starting sometime this afternoon, we'll try to communicate that. We do have a little bit of work to do to get all of the questions that need to be answered in the scheduling process there. For those of you who are not established, you'll be able to go to our website, the covidvaccine.kansashealthsystem.com website, and indicate that you'd like to receive your vaccine here. So you see name, date of birth, your gender, and address. These are ways that we can contact you and help create sort of a scheduling account for you. There is an occupation drop-down that currently has a list of a smaller list of things. The essential worker piece there will be updated to include the categories that I just mentioned very, very quickly here today, so that you'll be able to signal that you're in one of those populations, and that will let us know that you are able to be scheduled here, and our team will work on getting you an email version of how to do that. So for both our patients and those not our patients yet, but would like those who would like to be considered for vaccination appointment scheduling here, these things will be your tools to get there. Of course, you're welcome to talk to your providers, your physicians. There are offices or clinics here if there are questions or specifics. But this is exciting because it does go from probably 1,000 to maybe 2 or 3 or even 4,000 doses here. And that same thing will be happening next week across all of the community healthcare partners with Johnson County in improving the rate of vaccination. And we do expect that this is to some degree a little bit of a one-time bump as we're running out of phase 2 or moving into other areas of phase 2, I should say, and getting closer to phase 3. But we also know that starting really with the next couple of weeks, we've indication from the federal government that doses will be increasing to states as allocations, and therefore to counties, and even returning to doses to healthcare providers and the other 700 or so vaccination sites on the 1,400, give or take, vaccination site list in Kansas that are not actually providing vaccination now. As doses increase, they'll really get ramped up and be places across the state and our community where anyone interested in the current phase, and very quickly here, right by May, anyone interested at all who's over 16 can register or get their vaccine. So lots of good news there. Of course, 2 or 3 or 4 times the number of doses is still not as many as we could do, or as many as we would like to do, or as many as we know we need to get to the community quickly, but it's definitely a start of what we hope to be and do anticipate to be big things over the next few weeks. So lots of good Friday morning news there. I think we'll move on now then to questions from the community. Jill.
That was great. I'm perfectly fine with all the great news that you just shared. And Gretchen thanks you too, because her kind of leads into her question, because she was watching the president, his address last night, and wanting to know about, with the report of 600 vaccines going to waste in Lawrence, she's worried about, is that really just a boo-boo? Are we prepared? And it sounds like that we are, and we're moving forward.
We are. I don't think anyone knows with certainty all of the details around the doses that were reported last night, the Johnson & Johnson doses in Douglas County and Lawrence, and what exactly all of the variables were that led to that scenario. So we can't really speak to that. But if the question is, are we prepared, are we ready? I think the answer is yes. We feel very comfortable that we have worked out the details of how to manage now a third manufacturer of vaccine that has different logistics, and while there is, of course, always in that handoff the sender and the receiver, and making sure that there's the correct communication based on the manufacturer and the specifics with that dose, we're comfortable that our team has made connections, all of the connections that we need to there, and has the process in place, including some double checks. But we know that mistakes happen, accidents happen, and so 600 doses is not a little number, and it's, I think, hard for everyone, but it's also not thousands, and so we'll take what we can out of that scenario, I think, both in Lawrence and really across the metro and probably across the country. We'll take what we learned from that and make sure it doesn't happen again, and we'll keep on moving forward with what we can control.
Okay, so we have 2 or 3 really good questions that have come in this morning. I'm going to do those. Then we're going to move to the ones that we've had left over. And if more people have questions and we have time, then we'll do some on the tail end. Annette wants to know, is it safe to get a massage now that I am fully vaccinated and the massage therapist is fully vaccinated?
Well, that would be included in the new CDC guidance. And depending on your state can create guidance based off of the CDC guidance. So I would say look at what your state of residence is saying about 2 fully vaccinated people indoors. But per the CDC's new update, that would be a safe activity to do.
Mm-hmm. Pam wants to know, are you seeing long-term neurological issues? My 13-year-old daughter is still having issues 3 months after COVID diagnosis. Thank you.
You know, this might fall under the category of that post-acute SARS-CoV-2 sequelae. I don't think we know all of the ways that it does affect us after infection, and certainly we're learning more every day. I think if there are still issues, definitely get your child into a pediatric neurologist or a neurologist to kind of just get an evaluation and make sure it's not something different. We also know, we've heard that other things continue to arise. We heard about people who die after the vaccine. Well, we know deaths occur for one reason or another, even after the vaccine. That has nothing to do with the vaccine. So I would say if you have a concern, please get your child or get yourself to your primary doctor, and then get evaluation and see if you need referral to a specialist, i.e. in this case it would probably be a neurologist.
I agree. I think, it's very possible that those sort of long-haul symptoms are related, but in a 13-year-old, or really in anyone for that matter, as Dana mentioned, other health conditions are going to arise that were going to arise anyway regardless of a COVID infection, and so we don't want to chalk this up to only that. If you have concerns, please do reach out to your pediatrician and make sure that there's a connection to the appropriate specialist for evaluation. On the long hauler front and the post-acute sequelae of COVID, our team here, really the combination of the health system and the university side, is really focusing on what that impact might be, not just in the sense of developing our adult clinic for long haulers, but also in understanding what's happening with continual symptoms in the population of patients that we have taken care of, both in the hospital and who didn't need hospitalization, who've had COVID. And so that, I think, will be a very large focus of research, both here and across the country. The NIH has signaled a significant amount of interest in funding what that looks like over the next probably several years. And I'm excited. We're working very hard to make sure we can remain connected to that and understand what's happening with our population of patients here, and also with what might be slightly different, say, in a pediatric population or even in a rural population, where different coexisting health diseases may be more prominent. So lots more to come on that front. I think we'll be talking about this for quite some time, maybe years.
And Kitty had a question for you, Dr. Wild, on the announcement that you made. She wants to know, in the categories that you mentioned, she said, will they be able to receive their vaccine in other counties besides Johnson County? And if you're going to go through and sign up here, do you have to have a Johnson County zip code?
So for right now, this partnership with Johnson County is aimed to support vaccination for those who live and work in Johnson County. So for the next week or two, I would imagine that answer is yes. You must be connected to Johnson County and be able to sort of prove that if the county were to ask you. We've been asked just to make sure that there is a Johnson County address on an ID at the time of registration, or that there is some degree of proof of connection to employment in Johnson County. So I think that's the sort of plan at the moment. As far as will people in other counties be able to get this in their county, each county has been able to set their own guidance on what the population they will tackle first and second and third and fourth inside phase 2. Has to be within the phase 2 guidelines set by the state, but the order or sequence that they'll tackle those individual populations, or if it's just anyone in phase 2. So the announcement is pretty specific to what Johnson County is asking us to help them with, but all of those categories are included in phase 2 in every county. And so even if next week isn't the answer, it will be very, very soon, as most counties are working towards completion of phase 2 and moving on to phase 3.
Okay, and we're going to move to the next questions after you answer this. People want to know what sequelae is. Is that a new side effect?
Sequelae is, think of it as long-term symptoms and complications. And that is the term PASC, is sort of the medical and scientific term, post-acute sequelae of COVID, that has sort of arisen in the literature. And so it's a great question. Yeah, it simply means that there are consequences, if you will, things that didn't exist before that now exist as a result of having an infection from COVID.
Yeah, and this is just a general medical term. It's not specific to COVID. Anytime you have an infection or have something happen, it's about an after effect, essentially.
Yep, we learned a new word, and I want everyone at home to know that you guys do this to me all the time. All right, first question from the.
It's got a Q in it.
I'm learning.
It's good for Scrabble.
Yeah, it is. There you go. That's a positive spin. All right. Is herd immunity like a light switch that turns on suddenly, or is it more of a dimmer? When will we know we have it?
Yeah, so I think it's an interesting question. We've seen the experts postulate that it's a range right now, 70 to 85% we see typically. I think we will see some effects of achieving herd immunity as we get closer. I think the point for the community is we need to get everyone vaccinated as soon as possible, as many people as possible, so that we don't have to worry about more variants that may interrupt us achieving herd immunity. And so I think that's the key is making sure we utilize our resources now to get there as soon as possible, because the longer it takes, the more it's likely to have different mutations, variants, things that can make it more difficult for us to achieve that.
The question then about, how do we know we've achieved it? How do we know when we're there? What is the measure of success?
Yeah.
Because this is a bit of a dimmer compared to an on and off light switch, right? It's not like at 38%, or actually let's use a number that may be in the range estimated. At 68%, you don't have herd immunity, and at 70%, you do. The more or the larger the percentage of the people in a population with immunity, the less likely they are to transmit the disease to someone else, even if they are exposed or they have mild symptoms. And so that sort of dimmer comparison, I think, is good. The how do we know part is, when we start seeing declines in transmission, new cases as the best marker of transmission, with the same level of testing as a caveat, of course. We could see declines in new cases for a lot of reasons, one of them being people don't get tested. So we have to always account for that. But if the same number of people are being tested, or even more people are being tested, and we see fewer cases, that's how we know in a population. And I'll give you an example that's very tangible we've shared before. Here in the health system, we were experiencing somewhere around 25 new positive employees per day in December when we started vaccination. And now, with more than 80% of our employee population vaccinated, our average is less than one new employee positive per day for the last 7 days. That is the marker, right, that herd immunity in our population, called the 14,000 and change employees that work here in Kansas City. That is the marker that herd immunity in that population has been achieved. Now, when we talk about the bigger population of the state or the country, right, that gets a little bit harder, but in these subsets, simply because the numbers are bigger. I should say why it's harder, because we're talking about 330 million adults, and we're nowhere near 80%. That's obviously a different sort of challenge than 14,000.
All right, with Easter around the corner, is it safer to go to church now than last Easter? What are you recommending? And I want to add Isaac's question in here. Everybody that's coming to his Easter party, apparently, or gathering, they're fully vaccinated. He's only going to have had his first dose. He wants to know, am I okay? Can I take off that mask and hug and eat?
Yeah.
What are you recommending?
I'm going to start with the Easter church question. I've been thinking about this the last couple of days, mostly because we've been seeing all of the advertisements about, there's an ESPN show about the shutdown of the NBA and the NCAA tournament last year. Just thinking about that because we know we have the Big 12 tournament going on, and it was this time last year that it got shut down, and the St. Patty's Day parades got shut down. Is it safer? I think that's a difficult question. I think it's different. I think there probably wasn't as much widespread infections going on. I think there's definitely more community spread now than there was at Easter time a year ago. But I think it's different, and I think you have to understand you can reduce your risk of getting the infection. First of all, get your vaccinations if you are able to. Second of all, we know that there are behavioral mitigation strategies that we can take to reduce your risk, and that is masking, distancing, not meeting in those large groups. If you're going to church, we still recommend against singing. And we know that a lot of churches and parishes have done a lot of stuff and have a lot of procedures in place to help reduce your risk, either while you are in the building or even being able to do it and listen to it in your car. So if you can take those things into account and continue to do the behaviors that we know will reduce your risk of getting it, I think it's just different. I wouldn't say it's safer than last year, again, because I think in April or early April last year, I don't know that there was necessarily widespread community infection as there is now. But it's different, but we know there is widespread community infection now. So if you can do those mitigation strategies, that will be the best thing to reduce your risk of getting it.
Completely. You think of this like, right, it's one big equation. There's lots of different variables here. So last April, we really didn't know a lot. We weren't masking, right? Not nearly like we are now. We didn't understand all of the transmission dynamics. We didn't know all of the specifics about how infectious you could be before you had symptoms. From that perspective, we know a lot more. And in those cases, right, if we're doing all of the things that Dana just mentioned in the sense of mitigation strategies, it probably is safer. On the flip side, another variable in that equation is the degree of community spread. And remember, we are way, way, way above where we were last April for the rate of community spread and community disease. We're still sort of in the number of new cases per day. We're in the July sort of time frame where we were, which was double or triple or probably even more. I have to think about the curve, but definitely far and above the rate of community spread and community disease last April. So is it safer? In some respects, yes. Definitely from the perspective that we've learned a lot and we've given you the tools on how to keep yourself safe. If you do all those things, it's safer than last year. But just remember, there's far more people in that church or in any community, that church community or your community as a whole, your neighborhood, anywhere, who are positive today than there was a year ago.
Yeah. In regards to the second question about the party, I would really recommend against not meeting together. The CDC guidance does say fully vaccinated people can meet together indoors with their masks off. But it also says to refrain from having moderate to large size groups as well. So you have to determine, and I don't know that we've made really necessarily a determination of that. Historically, it's been around 10 people for one reason or another. But if you have not been 2 weeks from your second dose, then you would not be considered fully vaccinated. So you would probably still need to wear the mask. Even at that get together, I would encourage, outdoors is going to be better than indoors. Continue to distance, do those things that we've talked about.
All right. Can you speak to the 30-year-old mom who died just 2 days after her second shot? Sounds like it was liver failure. Could an immune response cause liver failure?
Yeah, we were talking about this. I'm not sure about that case, or I've even seen the reports. We know that people can have autoimmune hepatitis, which is an immune response, your body acting against its own tissues, particularly your liver in this case. But I'm not sure of the for this, if it's after a vaccine dose, we don't have any indications from the tens of thousands of doses that we've given here, from the more than 2 or 3 million people that have been on vSafe, which is the app to look at different effects, but also the VAERS, which is an adverse events reporting system for vaccination that has been around quite some time as well. I don't think we have any indication that there are those fears from the immune response and the reactogenicity demonstrated by the vaccine causing that in your liver. So would definitely need to see the details of that specific case to comment further.
Yeah, I would agree completely. I think, I've taken care of plenty of patients with autoimmune liver disease in my career. It's very, very rarely something that's acute, meaning comes up in a day or two. So autoimmune liver disease is
2 days
almost
is pretty
always
quickly.
something that's chronic. There's scarring you can think of inside the liver, and it leads to liver failure, not something that happens immediately. There are plenty of causes, including some potential immune reactions to a virus, for example, that can cause organ failure, even liver failure, in a short time frame like that. But it's I think we have no evidence that that reaction is something that happens to the vaccine. So like all of these conversations about someone that I know had X, a heart attack, or died 4 days after the vaccine, or got cancer, or you name it, we've heard all of those questions. I think this is similar to that. It's very, very, very likely that the liver failure and the vaccine were completely unrelated. The liver failure was going to happen anyway because there's a rate of that in any population, regardless of vaccine or COVID.
Yeah, and like you said, 2 days is pretty quickly. Even for acute like Tylenol liver failure, that's pretty quick. So I think understanding the details of that case is probably important.
and Roger, kind of tagging on to that, his wife, recently, right after she had her second dose of vaccine, is suffering with Bell's palsy, and he wants to know, can that be caused by the vaccine?
I have to remember back. There was some initial things of Bell's palsy, I think, in some of the initial reports of the Pfizer.
I remember it was very similar to what you would expect in a general population of people, because it can happen without reason.
And we know it can happen with COVID infection.
And it's not forever either, as I recall, right? You can get over it?
A temporary,
Yeah. All right, so moving to question 4, how can you convince a person that the vaccine is safe and effective? Someone I know believes that because it was produced in such a short period of time, it can't be that effective or safe. And Diane says that she has someone, too, that says, I'm not going to get that vaccine because there's only a 1% chance that I'll die of COVID anyway.
Okay. Yeah, I think addressing vaccine hesitancy is really important, and it's really important that we exhibit precision in the way that we talk about it. And I really like this topic. I think it's important to understand that people have many justified reasons why they may perceive pharmaceutical companies, medical institutions as untrustworthy. And so I think it's important to be kind and curious about their concerns, really try to understand what the root of those is. And I think exhibiting kindness and really not trying to lecture folks, but also understanding that with the rollout of these vaccines, we've talked about this a bit before, that it really is about, everyone, the whole world, their efforts were on getting these vaccines out. And so you didn't have to wait for participants. You had all the funding available to get them out quickly, get all of the phases done appropriately. And these vaccines did not skimp on safety at all, and we see that in the rollout. And also, another thing is manufacturing. So we know that we were manufacturing these vaccines right after basically the recipe was created, and we had them ready to go. That typically never occurs with a vaccine. You generate it, you get it approved, and then you start manufacturing it. So that has a lot of effect on the rollout and how timely that is. So I think be kind and curious about that, and then also come with facts and research, and listen to experts, and I think that's a good approach for those folks.
Yeah, I mean, I think we have to understand the key part in that person believes, understand why they believe what they believe.
Yeah.
Because if they are doing no research and just thinking it and it's their opinion, that's one thing. If they are doing their research, and it depends what their sources are, and if they are believing inaccurate or disinformation sources, then it's really going to be hard to speak with that person about that until they understand, what are the true the sources of truth, like you talked about. So I think there are many aspects, just as Lance had talked about. I think really the safety and efficacy issues, as I mentioned a little bit yesterday, really are diluted and diminished at this point in time. If you are vaccine hesitant because of safety and efficacy issues, and if you are reading the true information, the true facts of what really is going on, then you should be able to understand and see that really the safety and efficacy should not be an issue. There are other issues that Lance had talked about that are certainly valid as well, but just understand why that person believes what they believe, what is their source of the information that they're getting.
And I think it's fair game at this point to capitalize on the fact that there are some more motivations for vaccines now, where you can hug your grandma if you're both vaccinated. So I think that we all should benefit from the new research and the new guidelines from the CDC and from state health departments, in that there is some more benefit to getting vaccinated.
And I might come back for a minute, because I do think it's a really important point. Lance, you talked about the recipe being ready. Like, we were making these even before they were approved as the trials were going on, which is something that never happens. But there's also some really important history here. We were actually really lucky that the mRNA vehicle for the Pfizer and Moderna vaccines was actually being studied for a decade as a potential SARS or MERS vaccine. And that vehicle was never really needed because those diseases, I don't want to say fizzled out, but they didn't grow rapidly, right? They didn't become widespread like COVID-19, like the SARS-CoV-2 virus did. But the fact that we had invested, and I mean that as a global we, right? We had invested for a decade in identifying the right vehicle to rapidly be able to create a vaccine for a coronavirus that we didn't even really know was coming at that point. We knew something would happen, but that's one of the really, really big reasons this was able to happen so quickly for those first two, right? The Pfizer and the Moderna vaccine. And so that mechanism, although it had never been really used in a widespread manner because we hadn't needed it, that vehicle and that mechanism had been studied for a decade or more. And all of the time and effort that had gone into that meant that this was much more rapid, and that we had years of a safety profile for that vehicle and mechanism. And then it was really just checking the actual clinical response and safety profile for this specific vaccine. So those are all reasons why this was faster than what we've seen before. And it's important, right? That's a lot of technical information around why you can respond to someone and say, there are a lot of good reasons that this was as fast as it was. And it's not that there was a compromise on the safety or the research or the study.
Okay, this may be a yes or no, I'm not sure, but have you seen any data on those with immunosuppressed autoimmune conditions having negative reactions to the vaccine?
No data.
No, I've seen people with immunosuppressed conditions who get COVID, and they are at the same or greater risk of having worse outcomes than people who aren't immunosuppressed. The biggest thing I would worry about, if your immunosuppression is great enough, you wouldn't mount an immune response to that vaccine. But as far as safety, I don't believe there's any safety concerns at all.
Right.
I am a high school teacher and a single mom to a toddler with a genetic disorder that makes COVID-19 a high risk of death for him. I've received both doses of the Pfizer vaccine. My only options are FMLA with no pay or return to school to work. Can I still bring COVID-19 back home to him if I return to teaching?
So theoretically, that would be possible. I don't think we could really give absolutes in this question here, but I do think that getting vaccinated is the right choice for this person in order to. The thought is that you do have some reduction in the way that you can transmit it. Of course, we don't know that fully, but that does help. inform some of the decisions that the CDC and the states have made on what vaccinated people can participate in. There is some really helpful data that's supported in the CDC's updated guidance for school openings and school in person. One of them was a great study in Wisconsin that studied many public schools throughout Wisconsin. And showed that if they can participate in masking, distancing, some of that bubble activity like cohorting, that is all listed in the CDC's guidance, that you can function safely in a school. So I think that I would be interested in my own school's policies on what they follow and be sure that that aligns with what I know is a good, safe approach for live school.
All right, does the University of Kansas health system include the antidepressant, and I can't say this word,
Fluvoxamine.
thank you, in its COVID-19 treatment options as reported on 60 Minutes? I think that was just over the weekend, too.
Yeah. No, the short answer to that is no. There's no NIH guidance on that. So, the mainstays of treatment for COVID-19 right now remain monoclonal antibody before you're ill enough to go to the hospital. This has helped to prevent severe disease and hospitalization. If you are in the hospital, it's remdesivir, which is an intravenous or IV direct-acting antiviral drug. Also, tocilizumab, which is a drug that helps reduce the immune system or the inflammatory cascade. But that's only if you're sick enough to go into the ICU. There is another one as well that's similar to that, that's acting on that same inflammatory cascade. And again, you have to meet criteria to be ill enough to get those. The other thing is dexamethasone, which is a steroid. Again, you need to meet certain criteria to get dexamethasone as well. And then anticoagulation, which is blood thinner to help prevent or treat any blood clots that may occur. Really, the book has been shut on things like hydroxychloroquine, ivermectin, vitamin D, zinc, azithromycin, all of those things. I suspect fluvoxamine is going to be that way as well. Certainly looking for more studies, and if something provides benefit, would definitely want to use it, but there's really no studies out there, and there's certainly no recommendation to be using that in the NIH or the World Health Organization guidelines.
Okay, and I just want to speak out to Kelsey and some others that I'm seeing questions come along. We're going to have a video at the very end of today's broadcast that are going to help answer some of the questions about CDC guidelines. So stay tuned. Let's keep going on. Question 8 out of 10 that we have planned for today. What lessons from last year's spring break should we have learned during this pandemic and remember?
Loaded.
I think we all remember Missouri making global news last year with some spring break activity. I like the discussion we were talking about earlier about how, really we still should be as concerned as we were in summer, because it's important to remember that our perception of risk is relative to what we've experienced. So if we think about where we're at compared to January, we are in a lot better spot, right? But if we think about it related to last summer, with the spike of last summer, we're kind of right on that spike of where we were. So I think it's important to remember that. And I do feel much better about this spring break because I think that by last year's spring break, there's probably many people who weren't really impacted. Their daily life may have not been impacted at that point by COVID or the virus or, government shutdowns, things like that. Now I think we are all on the same page, and we're all so much more aligned than we were last year with what needs to happen. So I do think that we've learned a lot over the last year, and it hopefully will help us participate in safer activities this spring break.
Yeah, I agree with all of that. I think, this is sort of like the Easter service question. We know a lot more. We all have more tools, I think, in our toolbox to prevent ourselves from becoming ill. But there's still a large amount of disease burden, disease transmission in our communities. And so, as it pertains specifically to questions around spring break and travel as part of spring break, remember the CDC guidance from this week said even for those vaccinated, non-essential travel is still not recommended. And the reason for that is actually not necessarily that the act of traveling, if you do all of the mitigation steps, is more dangerous than the act of doing the same thing, going to a restaurant in your hometown. But instead, that we know when people travel, especially for holidays and things like spring break, they move across the country. They interact, right? Just it's our nature to interact with more people from different places, sometimes that we haven't seen in a while, in different ways to let our guard down. Then add to spring break things like adult beverages that may decrease our ability to make the decision that we might make in a non-adult beverage situation. And all of those things have led, every time we've seen people travel in the last year, have led to a new series of outbreaks, if not a surge. And so that concern very much exists, that although we are better today, without a doubt, than we were a week ago or a month ago, or definitely than we were, say, in November or December, the pandemic is not done. It's not over. And until we really know that there is the degree of immunity necessary in our population to prevent a big outbreak, and we know we're not there now, right? 10%. 10% of the national population has received both vaccinations. So 1 in 10. We're not at the point where spring break can look like spring break from previous years.
Okay, and a shout out to Pamela. Watch on Tuesday because we're going to be talking more about the long hauler clinic, and we'll answer that question that you have. And it's a great question, so more to come from Pamela on Tuesday. Yeah. Question 9. It feels like there is a race between virus variants and vaccinations. Is there enough protection from the vaccines that we can celebrate spring gatherings safely? What has to happen to no longer be considered being in a pandemic?
That's a big question.
Our viewers are tough, I'm telling
Mother
you.
Nature is always going to be 1 to 2 steps ahead of us. And certainly we've seen this with bacteria easily developing antimicrobial resistance, so resistance to our antibiotics. The same thing with the virus and its ability to mutate or change, it seemingly under not even a lot of external pressure to do that. So certainly, but I think we do have some good news from early data from the Johnson & Johnson and Pfizer about their vaccines and their ability to continue to be efficacious and give immunity against those variants, especially the variants that we know about right now. Obviously, other variants can arise, but I think there is a good reason to be optimistic about that. And then, when can we celebrate spring gatherings safely? I think we still need to continue to do those things. I don't know that we have a crystal ball as to when we will be able to do that. We know about the behavioral things that we can do to help reduce the risk of spread. And again, it's not just spread to you as the individual, it's to spread to other people you may love who may be in that more vulnerable population. And when will it be considered to be not a pandemic? I think that's a good crystal ball question, and I think we have to look at what are things doing around the world. I think we are very fortunate right now in the Kansas City area with our numbers and our hospital capacity and our ability to have our essential workers continue to be working and not at home ill or in the hospital. But if you look at places like Brazil that is being hit hard now, we know that some places in Europe are particularly being hard hit as well after some lifting of their restrictions as well, or in the UK. So I think we just need to continue to watch how are things locally in our region, but how are things nationally, and then, of course, how are things across the world. And that will be the biggest bellwether of when we can consider this pandemic no longer to be a pandemic.
Yeah, and I think the question is also, how do you define the end of the pandemic?
Yeah.
I think some people could say, well, the World Health Organization can, just like they said this was a pandemic and announced that, I think a year ago yesterday, that they can also say, well, the emergency section of the pandemic is over at this point, right? With whatever rate or measure they may see for that. I don't think it's unreasonable to think that a resident of Texas may think that the pandemic is over, and that is the legacy of the United States having a state-by-state response. We may see different states lifting different orders or activities at different times, and you may have a different perception of when the pandemic ends for you, but really it's so important for us to remember that the pandemic affects the globe. That's the whole point. It affects everyone. So we all have to be in it together collectively for it to end. And I have seen some interesting information on measuring the end of the pandemic using kind of like a flu strategy. On average, every year we see 100 deaths of a day from the flu. And so, if we get to a point like that, we would say that would be a point where we could potentially...
endemic disease,
yeah,
right? A chronic level that exists without these surges, and that would be a good signal too, I think, a good objective measure.
Final question for today, or do you want to comment on this?
No, I think I was only going to reiterate the sort of recognition Lance hit on. The World Health Organization decided, right, when to announce that a pandemic, an infectious process that was impacting the world's population, happened, and it was several weeks after first cases. Again, from the perspective of a pandemic is truly something that is a global problem, large population sense global problem, not just geographically global, and we're definitely not out of those woods yet. It's some time before the pandemic is done. Just to sort of reiterate as well, as of Monday of this week, although the United States only has 4% of the world's population, it was more than 30% of the doses of vaccine administered worldwide had happened here in the United States. So there's a big gap to close to be able to say that this disease, this virus, is not at risk of infecting people across the globe. Just a reminder, it will be some time before we tackle all of that. The 330 million that we're talking about in the United States, for example, 4% of the overall problem we have to tackle. So with travel, the ease of international travel, not saying right now with restrictions, I'm just saying the fact that we can get on an airplane and in 8 hours be somewhere a quarter of the way around the globe, will mean that until we have tackled this problem across the globe in its entirety, there will always be risks of sort of flares and surges. And even if we maybe have things here okay in our own little neck of the world, whether, right, as you said, it's this sort of state-by-state comparison or even in our community, we do have a bigger picture to pay attention to because the risk isn't really gone until we've addressed that issue globally.
All right. Big shout out to our viewers today. They asked the toughest, smartest questions, and I'm really saving you guys from a lot of the really tough ones today. They're on fire. Final question. Do you think we will always be wearing masks in some places like airports? Where else might masking still make sense post-pandemic?
Well, I think in the least, we know over the last year, we have so much data that suggests that masking is really effective at stopping respiratory viruses. General masking, as evidenced by flu this year, which is almost non-existent. And so that's clear that, there may be some like seasonal masking activities, at least in the near future. And then, I think what I appreciate about this is we've normalized mask wearing, especially if you're sick and you have to leave your house. In our society, we've never really done that historically. So I think that is really good, that if you do have, mild symptoms, maybe you even have allergies, just as a caution, wearing a mask if you had to leave your house. And this is in the future, right? Where that would probably be kind of weird before the pandemic in our society. So I think that that's a benefit of this, is that if you are sick, that's a great way to contain the particles that come out of your mouth and keep others safe.
It isn't really a great question. Will we be wearing masks in specific places or circumstances for some time? And I think in many ways, the answer is that would be a great outcome of all of this. And I say that because not only have we talked extensively about the reduction in influenza this year, and it is dramatic. I don't think we can say that enough and often enough or loudly enough. But even in that conversation about travel and the global impact of this disease, it's very likely that even with a great acceptance of vaccine and a vaccination campaign that gets to the right percentage of the population, it's very likely that we continue to see little fits and starts, peaks and valleys in the number of cases, new cases per day for some time, sort of like influenza. Maybe there becomes a season or something, and we may find ourselves sort of coming back and forth between, okay, there's not much disease now and we don't need to do these things, to, oh my gosh, in our area, all of a sudden we're seeing a little outbreak and we are going to go back to masking for a period of time to get it under control. And that may also be in places or specific activities. Airports make sense, places where there are lots of people, or especially places where there are lots of people that aren't outside. And I don't mean to say that that'd be a great outcome in the sense that I'm trying to, normalize something that is maybe not positive, the fact that we may have disease with us for quite some time, but instead that we know the benefit of this, and we've seen it over and over and over again. And it just does truly become, in the big picture, in the long run, another tool in our toolbox to make sure that we're safe, that our families are healthy and safe, that our community is healthy and safe. I can see that happening, and I would view that as a positive thing.
Yeah, I mean, I think we would all love not to have to wear the masks anymore. But what is best for individual and public health right now is to continue to do that. I don't envision a time where we will not be wearing a mask in the hospital, in the healthcare setting, to keep our employees and our patients safe. Hopefully in other maybe social areas and social settings, we can get to that, but I think it is a long time off now, just for the reasons that you stated. And, we are always, just as we were talking about increasing and decreasing numbers, I think we're all concerned about what's going to happen in the spring with spring gatherings, with graduation parties, with trips or other things where people are getting together. We could certainly, I don't think it's inconceivable to think about our numbers here and active infections going up to 20, 30, 40, 50 again. That is just something that we are going to have to take on day by day and kind of look where we're at. It's really hard to have that crystal ball. But we certainly are always ready and prepared for those surges or those increase in cases, because we know it doesn't take much for that to happen.
Truly excellent questions today. Many of them required long answers and lots of commentary, and I think that's a great signal that we're asking the right questions as a community. So thank you all for that. On Monday, Ed O'Malley with the Kansas Leadership Center is back to update all of us on the Kansas Beats the Virus campaign. If you remember, the goal was 1,000 community meetings before the end of last year to educate and prepare the community for how to beat the virus. We look forward to the findings from that work and a special guest that Ed will be bringing along with him. Gentlemen, final thoughts this morning?
I'm just we've had this hygiene momentum that I've been thinking about, and we just need to sustain it. Is what I want everyone to focus on. I know it's resiliency is so important right now, and so we have some hygiene momentum. We need to keep it, and then what can we keep even after the pandemic? And I always have to plug hand hygiene and how it's the best way to keep yourself safe from germs.
Yeah,
spoken like a true infection preventionist. Yeah. Thank you for that.
Hygiene momentum is important. I'd like my teenage son to shower on a regular basis, please. Use soap. So that is always good. I think it's going to be somewhat nice this weekend. I think there are calls for some storms. So if you can get outside and maybe work in the yard and seed your lawn if you need to, that would help. And get outside when you can in between any storms or anything like that. But just continue to remember, although the new guidance is there for vaccinated persons, if you are unvaccinated, continue to do those things, even if you are vaccinated. Really be vigilant now, because we have such good low numbers of infections in the Kansas City area. Let's keep it that way. Continue to mask. Distance as much as possible. Outdoors is better than indoors. Don't meet in large gatherings, and really keep everybody safe.
As I think back on this week, a pretty momentous week, a year, a marker of a year of this sort of conversation and work, a reflection on how much we've learned, on how our community has so many times and in so many ways stepped up to keep things from getting truly out of control. That kind of sort of concept that we might have bent at times but not broken. There was a note forwarded to me after, I think, Monday or Tuesday morning, but someone noticed that in the slide deck, there was a chart that had a time that the data was pulled that was 1:29 or 1:37 in the morning, and a comment on, gosh, you guys must never sleep, and that the commitment is appreciated. And I think that is true. We have learned how to go at a pace that is probably not sustainable for decades over the last year, but we're very proud to do that. We understand that that's the commitment we made, both as healthcare workers and as an organization, to our community. And we appreciate the interaction, the feedback, the chance to have these conversations, to field your questions, to make sure that we do share the best that we know and tackle the things that may not be the best answers that are out there floating around. So we know that each of you have played a part in our success over the last year as a community, and I ask that you keep doing that. We're not quite out of the woods yet, but we're definitely closer. I think there's a question next week about what inning of the baseball game we might be in as it pertains to the pandemic, and I'll be curious to see the answers. I think I know where I stand. But as we go into the weekend, as Dana mentioned, it is, I think, expected to be nice, but potentially wet. Be safe. Continue to do the things you know that can keep you and your family safe and healthy. As we wrap up this week, we fielded a lot of questions about the updated CDC guidelines on pillars of infection control and changes in behavior as you become fully vaccinated. Here's a recap of what you need to know. You feel free to share as you watch today. We'll see you Monday. Have a good weekend.
For fully vaccinated people, they are able to gather indoors without masks. If you are a fully vaccinated person, you are able to meet with one other household with people who are not fully vaccinated, provided there is nobody in that household that is at increased risk of severe COVID-19 infection. Why is it one household? Well, again, we want to make sure that if there are unvaccinated people in that household, that if there is disease spread, it will be limited to that one household. They also do recommend that you still cannot get together in large groups or medium-sized groups. If you are fully vaccinated and have that immunity, you are able to not quarantine or test if you have been exposed to somebody who has COVID-19, unless you have symptoms. The other important thing to remember is that if neither party is vaccinated, again, you need to continue to do those things that we've talked about, and that is masking, distancing 6 feet or more, not meeting in large gatherings. If you are meeting, outdoors is always better than indoors. Continue to do those things until you can get that maximal immunity and full vaccination status. Then remember that these new guidelines are for fully vaccinated people, and that is people who have received their second dose of Moderna and Pfizer, or received that first dose and only dose of the Johnson & Johnson vaccine. And to consider to be fully vaccinated, it is 2 weeks after those doses.